Dear colleagues, my name is Milunka Milinkovic from Institute of Public Health of Serbia. Today I will present results of our study, risk factors for severe acute respiratory infections among influenza positive cases in Serbia during the season 2014-15. As we all know, influenza is a disease that causes considerable morbidity and case fatality among high-risk groups. Pandemic of H1N1 revealed the need for surveillance on severe forms of influenza. Most of the available research about risk factors for Sari are from developed countries of the EU as well as the USA. In Serbia, we have established a surveillance system on Sari since 2009, and during previous season, we observed increasing number of Sari cases, with a peak in 2014-15. In Serbia are also limited information about risk factors for Sari. Here is the flowchart of surveillance system on influenza in Serbia. We have a network of 23 regional institutes of public health that collected data for influenza cases during influenza season from primary healthcare centers as well as secondary and tertiary healthcare facilities, and send them to the National Institute of Public Health. We also have for laboratory surveillance 2 national influenza centers that provide virological examination of specimens. The objective of our study is to identify the risk factors for Sari among laboratory confirmed influenza cases in Serbia during season 2014-15 in order to apply adequate preventive measures among high-risk population. As a method, we analyzed national surveillance data about laboratory confirmed influenza cases during season 2014-15 from 40 to 20 epidemiological week. We used WHO 2011 case definition for Sari. Sari is an acute respiratory illness with the onset in the previous 7 days, requiring hospitalization overnight, and history of fever or measured fever more than equal than 38 degrees of Celsius, and cough and shortness of breath or difficulty of breathing. As a data collection tools, we used a case-based reporting form for laboratory confirmed influenza cases. This form includes socio-demographic characteristics of cases like age, gender, occupation, clinical signs and symptoms, underlying conditions such as chronic disease, chronic respiratory cardiac disease, chronic diabetes, immunocompromised status, then obesity, pregnancy, then vaccination status against seasonal influenza, laboratory data about identified type or subtype of influenza, and outcome. We collected nasopharyngeal and oropharyngeal swabs and sent them to 2 national influenza centers for testing by real-time PCR method. We performed descriptive analysis, univariate analysis. All variables that were associated with Sari at level p less than 0.2 were included in multivariate logistic regression. As a software, we used the SPSS 21 software. Here are the results. We can see that the total number of influenza positive cases in this season was 369. Distribution by gender was almost equal by males and females. Predominant type of influenza was AH1 PDM with 44%, followed by AH3 with 34.1%. We can see that is only 1.6% of lab-confirmed cases was vaccinated, and Sari had 64.5%. With fatal outcome was 34 cases. That means case fatality ratio was 9.2. The mean age was 42 years and the median was 47 years with a large range from 1 to 90 years. Then chronic disease had 52% of laboratory confirmed cases, and the most common chronic disease was chronic cardiac disease. Also, we can see that pregnancy had 2.4% of all positive cases. Here are the results of univariate logistic regression analysis. We can see the highest odds ratio had a person who had chronic respiratory disease, followed by chronic disease and immunocompromised status. We considered age as a continuous variable. So odds ratio was 1.1. Here are the factors that were independently associated in Sari in multivariate logistic regression. Age with odds ratio 1.05. That means for 1 year increasing in age, there was increasing for 5% for developed Sari. Also chronic disease, odds ratio was almost 6. That persons are 6 times more likely to develop Sari. Pregnancy has the odds ratio 8.6. But we can see that is a large confidence interval because that was a small number of pregnant women. And the type of influenza AH1 PDM had odds ratio 2.8. That means that those persons who were infected with these types were almost 3 times more likely to develop Sari. We can say that data from the surveillance system can be used as a tool for identification of risk factors for development of Sari among influenza positive cases. And the results of our study are in correlation with the similar investigation about risk factors and also in accordance with the WHO recommendations. Limitations of our study, we had a limited number of lab specimens among cases that were not Sari patients, and that can be a selection bias. So we can conclude that in Serbia during the season 2014-15, risk factors statistically associated with Sari were age, chronic disease, pregnancy, and infection with influenza AH1 PDM. For recommendations, the most important is to increase vaccination coverage of the vulnerable population by public health promotion of vaccination as the most effective measure of influenza prevention. Also, it is important to increase awareness among high-risk group, also by public health promotion and healthcare seeking behavior. And it is important to maintain and continuing with the epidemiological and virological surveillance. And for acknowledgements, I want to thank Dragana Dimitrijević, who is national focal point for influenza in Serbia, Anita Grgurević, MediPIET supervisor, our past director Dragan Ilić, who was very commitment to MediPIET, Nicoleta Mavraidi, our scientific coordinator, and the network of regional institutes of public health and 2 national influenza centers in Serbia. Thank you.
Milunka, thank you very much for great presentations. And I would like to mention that in your presentation we find out 2 additional very important method for data analysis. And it's good that you use in your data analysis such methods as unvariated analysis and multivariated logistic regressions, what give you the chance to have very clear data, and you can prove during your presentation at the end, you can prove and recommend very specific measures like vaccination, and with focus especially to dedicated risk groups and especially persons with chronic respiratory infections, what you mentioned in one of your slides. Congratulations, and now floor is open for discussions and questions.
Thank you very much. Konstantin Remish, Moldova. My question is just continuing our discussion of previous presentations concerning chronic disease and linked to the children. Could you explain, or could you say what is the percentage of children in your study group? This is first one.
In this study, we didn't divide variables age into groups. We observed as continuous variables.
Okay, I saw that you say 47 was the medium, but
yes, that was the medium.
1 to 90.
Yes.
I saw, but it will be interesting to see this part of the population, because you mentioned that the main risk is chronic disease.
Yes.
That's why it's interesting to see this part. The second question is, you mentioned and you did recommendation concerning increased vaccination coverage. Could you say what is the vaccination coverage now?
It is difficult to assess because we don't know denominators among all those groups who are recommended immunization.
Okay, thank you.
Thank you.
For the next.
I'm looking forward for other questions. Please, Professor.
Thank you, Milunka, for your presentation. It's really a very nice presentation. And I would like to know, I was wondering that you, in multivariate analysis, you told that you are using a continuous variable.
Yes.
In how you measure in continuous variables for chronic disease?
Sorry, how?
Chronic disease, how you measured as a continuous variables?
No chronic, age as a continuous.
Only age?
Only age,
oh,
yes.
So, okay. So the other variables you saw yes or no?
Yes.
Okay.
Yes,
Thank
as
you.
a categorical.
Okay, thank you.